ASH 2019, there are two important points that I would consider interesting. The first one is the treatment of low-risk, localized, no bulky diffuse large B-cell lymphoma, in which we can de-escalate the treatment comparing to the standard chemoimmunotherapy. And the second one is the treatment of the relapse refractory diffuse large B-cell lymphoma after second or third line, in which CAR T-cell treatment has definitely a role not only in clinical study but also in clinical practice. At ASH 2018 has been presented a study in diffuse large B-cell lymphoma in a limited stage in low-risk patient. That it means in IPI 010 without bulky disease. I think it's important to stress, comparing the standard treatment, that is Rituximab CHOP for 6 courses, comparing to an abbreviated treatment with only 4 courses of Rituximab CHOP followed by 2 additional doses of Rituximab. This study has been presented by the German Lymphoma Alliance Group and involved more than 500 patients, almost 600 patients. The patients were randomized to receive standard or experimental arm. The key point of the results of the study, there was a non-inferiority study, the 2 groups as experimental arms in which the patient were treated with 2 less courses of chemotherapy did as well as the standard R-CHOP with a progression-free survival of more than 90%, around 92% for the both groups. It is also important to note that if you reduce the amount of chemotherapy, of course you reduce the toxicity. Indeed, in the study there was less frequency of myelotoxicity and other toxicity. So in this type of patient, so far we had 2 approaches. One is only chemotherapy with 6 courses of CHOP plus Rituximab. The second one was to give an abbreviated courses of R-CHOP but followed by radiotherapy usually. And this is, for instance, is a standard approach in US. And I think that the most striking finding of the study is that you can reduce not only the amount of chemotherapy, but also you can spare the additional radiotherapy that usually you give when you give less courses of Rituximab CHOP chemotherapy. These clinical data, I believe, they are sufficient to change our practice in this group of patients, and because there are a very large study of more than 500 patients, well conducted, randomized, so there is proof robust enough that showing that we can spare 2 additional courses of chemoimmunotherapy in this patient. At ASH 2018 has been presented an update, the final results of the JULIET study. That was one of the first studies that addressed the CAR T-cell in diffuse large B-cell lymphoma. The update was done on 93 patients, and the results are quite similar to the preliminary result presented, in which the overall response rate is around 70%, the complete remission rate in the range of 15–60%, and the progression-free survival after 6 months is around 50%. It means that you fail, the patient who fail early, and then if they go over a 6-month time point, they usually do not relapse anymore. At this ASH 2018, there are many presentations regarding the real world data with CAR T-cell, because in US CAR T-cell has been approved since last year, so many sites have been using CAR T-cell for the treatment of this patient. MD Anderson Hospital collected patients not only treated at MD Anderson Hospital but also in other 10 or 15 sites in the US, and they collected more than 250 patients of the real world. I think there are two important points of this presentation. The first one, that the effective is as good as the clinical studies, and so it means that the results of the clinical study can be translated in the clinical practice. The second important point, that the safety is not so much different comparing to the clinical studies. CAR T-cell now are the best effective treatment for diffuse large B-cell lymphoma at second or further relapse, but taking into account if the patient is fit, if the patient has a good performance status, so we don't consider this treatment for disparate heal patient, because in this case it's too toxic and maybe you can't manage, you don't achieve a response, so you may have also side effects. So far, I believe that this treatment will largely replace allogeneic transplant in diffuse large B-cell lymphoma, and we may see in the future if we anticipate the treatment of CAR T-cell in high-risk patients, in patients who did not respond to R-CHOP or who relapse within 1 year after R-CHOP. These are very poor risk patients, and usually in this patient, high-dose chemotherapy, autologous stem cell transplantation produce a cure rate of less than 20%. I believe that in this setting, CAR T-cell may play a role. There are a couple of randomized studies just started a few months ago comparing CAR T-cell and autologous stem cell transplant in high-risk patients.